Good morning, people. We are really excited today to have Dr. Anitha Vijayan present to us early in the morning for her from Utah, Mountain Time. Dr. Vijayan is a senior medic now. She's a senior medical director for Intermountain Health Kidney Services in Utah. And before that, prior to that, until a couple of years ago, she was a professor of medicine at Washington University in St. Louis, where she was also the medical director of Acute Dialysis Services at the Barnes Jewish Hospital. She's got tons of paper, but what I think she wanted to highlight is that she's very passionate about patient care and excellence, and she's got numerous awards, including the WashU Dean's Impact Award. She's also led the ASN response to COVID-19 for dialysis in the hospital, as well as on the ASN guidance for the topic that she's going to talk about today on dialysis requiring AKI in the outpatient setting. Welcome, Dr. Vijayan.
Thank you, Swap, for inviting me to give grand rounds. Yes, it's a little early for me, but I'm happy to do it, and happy to connect with you and Ted and others, even though it's by Zoom. The topic I'm covering today will be the care of patients who require dialysis after hospital discharge, and I purposely titled it "The Road Less Traveled." I don't know if any of you are English majors or know poems, but Robert Frost's Road Not Taken actually ends with saying, he took the road that was less traveled. And this is exactly what happens to patients who get discharged, right? It's a road less traveled for them because they're going to a territory, outpatient dialysis, which is usually meant for patients with end-stage kidney disease. And it's also a road less traveled for the patient, for the caregivers, right? The physicians, the nurse practitioners, the nurses who take care of these patients in the outpatient setting. It's an unknown for them as well as these patients come into the unit. So that's what I wanted to try and highlight today during this presentation. And these are my disclosures. I do consult for dialysis companies, but they're not directly related to this talk. All right, so I'm going to start with some cases, and this is from my fellowship archives. This is a true case that happened to me when I was a fellow a long time ago. I'm not going to say 20 plus years ago, I say I was a fellow. So the 72-year-old woman came to the hospital, Barnes Jewish Hospital, which is a tertiary care hospital in a 300-mile radius, after a motor vehicle accident on her way to her dialysis center, which is in the rural parts of Missouri. So she had a splenic laceration and a femur fracture, and that's why she was airlifted. She had a diagnosis of ESRD, was on hemodialysis for almost 2 years, and as you can see, I put ESRD in quotation marks. She even had an AV fistula in place, and apparently ESRD happened after a diagnosis of acute kidney injury during her admission 2 years prior for mantle cell lymphoma. On asking about her dialysis history, and this is something I do. So a lot of the times when we admit patients who are ESRD, we just like, oh yeah, this is an ESRD patient, Monday, Wednesday, Friday dialysis, and you never ask the patient any details about their dialysis, right? Or some people don't. But I always make it an effort to try and ask them, well, what happens during dialysis? Do you tolerate the sessions well? Do you have any hypotension? Do you have other things? And she told me, oh yeah, I regularly stop dialysis in the middle of the treatment and go to the bathroom to urinate. I mean, if your patient is telling you that 2 years into dialysis, I mean, I think that's a time to take a pause and see, how much renal function do they actually have? She reports no interdialytic weight gain. And actually, when I presented this to my attending, he said, oh yeah, that would explain why, when I was taking a history from her, I had to help her off the bedpan because she had just made a lot of urine. So I held dialysis, and she went for a splenectomy and open reduction and internal fixation of her femur. I got a 24-hour urine collection in the hospital. It was 12. I held dialysis, and I told her, don't go back to dialysis when she leaves. But patients often don't remember a lot of things after they leave the hospital, right? So I had to really emphasize this, don't go for dialysis. And within a few months, her creatinine clearance increased to 17, and she continued to follow with me for 3 to 4 years, lived independently, and she'd love to mow her lawn. This is a stock picture, but she'd love to mow her lawn on her riding lawnmower. And she had a pretty happy, I would say, pretty good quality of life afterwards until she passed away. So, And then during the ATN study, so WashU, Barnes, we enrolled the second highest number of patients in the ATN study, 136 patients of the 1124 that were recruited. This patient was discharged to rural Arkansas, the state that touches Missouri, and the study coordinator called to get labs from the dialysis unit. And I remember her pre-hemodialysis K was 3, phosphate was 2.3, creatinine was in the 2s. Patient was reporting making a lot of urine, and no one had addressed that she could be potentially coming off dialysis at this time. So I personally called the outpatient nephrologist, and his response was, I still remember this, is that, oh, I'll do a 24-hour urine test as clearance. And I'm like, well, maybe you could just try to take the patient off and see what happens. And he got very angry, threatened to report me to my division chief, and said, Medicare already investigated me in the past, and they found nothing wrong with my practice. I'm going to report you. And but anyway, long story short, the next day the patient was off dialysis. And then, of course, a lot of you have heard Marla Levy's story. She is a patient at UCSF, and her story is on the UCSF website. And she talks about this transition. So she got AKI in the hospital after a complicated cardiac surgery. I think she was still in her 30s. She went to outpatient dialysis unit. The care there was completely unlike what she was receiving in the hospital. She describes a lot of miscommunication, not being seen by the nephrologist on time. And she was referred for vascular access, saying she needs she has ESRD, and the surgeon asked her to get a second opinion, sent her to Dr. Su, the UCSF chief, and essentially he looked through all her records and stopped dialysis that day. And her words are, I didn't believe it. It was being told I had won $100 million in the lottery. And I think all of us would agree, right? Stopping dialysis, watching a patient come off dialysis is probably the most good we feel during our career, right? It really is a feel-good moment for not just for the patient, but also for the nephrologist as well. And I always tell my transplant colleagues, it's even better than the patient getting a transplant. Why not just have their native kidney do the work, right? Take them off dialysis. So these are some of the stories that have prompted a lot of us to address this care of the patient in the outpatient dialysis world. And I think I apologized to SWAP already, but there's not a lot of data here, so this is not going to be a data heavy talk. But let's review what is out there. So the outline that I'm going to be talking today is what happens to a patient on discharge from the hospital, what are the challenges and opportunities, and policy and regulatory gaps. This is important for the U.S. market, not necessarily for Canada, but I will just highlight some of the challenges we face here in the U.S. and then what are some of the research priorities. So this is a figure that's still used widely. It's 10 years old, and I think it just shows that this is a very small but vulnerable population. So 20% of patients in the hospital may get AKI. Majority do not need renal replacement therapy, maybe 1 to 2%, maybe slightly higher now. Of those, 50% do not survive. Of the 50% who survive, they go to outpatient dialysis, and maybe 70 to 90% recover function early on. That might be a little higher, I would say closer to 75%. Then about 25% remain on dialysis. Of this, 50% mortality later on in the outpatient world. And then eventually about 40 to 80% of the remaining will develop ESRD. So after 90 days, very few patients, 1 to 6%, according to the earlier literature, may recover renal function after 90 days. But I think the point to highlight is that we should continue to see if patients are recovering even after 90 days. So AKI, this is a USRDS data, so obviously Medicare population. So percentage of hospitalizations with AKI that require dialysis, approximately 4%, that has held steady for the past 15 years. And if you look at the ESRD prevalence in the United States, it's about 500,000 for in-center hemodialysis, right? And I'm overlaying the AKI-D population. Again, data only started tracking in 2017. I'll come to that later in the talk. And only about 12,000 of patients. This is, again, Medicare population. There could be higher numbers if you include all comers. But it's a very, very small population when you talk about the ESRD numbers. And this is why, for one of the reasons why they're often forgotten. And again, USRDS data as far as outcomes during 6 months after initiation of outpatient dialysis. And you can click Medicare Advantage, Medicare Fee-for-Service in these USRDS data reports. I just picked one that looked very similar. And as you can see, in 1 month, 14% were transitioned to ESRD, and recovery of kidney function around 17%. And if you look at the 4-month mark, transition to ESRD, 42%. So that's after the 90-day. And then recovery of renal function was seen in about 32%. This is data from Javier Nera when he was at University of Kentucky. He looked at a small population of about 110 patients. And again, at 90 days, recovery was noted in 41%, 15% mortality, 44% progressed to ESRD. And you can see the time from hospital discharge to progression. So the longer they stay on dialysis, obviously it makes sense. They're less likely to recover renal function. And this is, again, from Javier's paper, where it looked at who were likely to not recover. Less kidney recovery was seen with older age, more comorbidities, lower eGFR at baseline, and for some reason there was an association with blood transfusions, probably just showing how sick these patients were. This is data from Fresenius that they published looking at their patients who came into the hospital, into their outpatient dialysis centers in the US. And somewhat similar data, transition to ESRD, 37%, persistent AKI diagnosis in 10%, and death was 10%, mortality was 10% in this population. This is also data from the Fresenius team on what is the mortality for these patients when compared to ESRD patients. And as you can see, the first 3 months, month 1, month 2, month 3, the mortality is significantly higher when you think about when you compare to the incident ESRD population. And by month 4, they even out, suggesting that the patients who are discharged from the hospital still have so many other comorbidities, whether it's just recovering from sepsis or having underlying cancer, getting chemotherapy. There's a lot of other things that happen with these patients, and their mortality remains high. So ASN Kidney Health Guidance, I think last year, ASN decided to come up with guidance documents on important topics that affect our patient population. So they really wanted these guidance documents to be very patient-centered, and they focused on topics. This was decided by ASN leadership, and now they have a steering committee for guidance documents led by Kathleen Liu, and they really wanted to focus on diseases that affect either a significant portion of the population or a small group, but still leads to huge challenges for that small group of patients. And the second guidance document that just came out is on acute kidney injury, what patients requiring acute kidney dialysis for acute kidney injury in the outpatient setting. And I was asked to chair this with Michael Hung from University of Michigan. So one of the things that we decided to do, again, as I said, there's not a lot of data in this area. We decided to, we had an external reviewer collecting all the literature for us. We also did our own literature review, and we tried to come up with risk factors, comorbidities, how do we predict renal recovery, what happens to these patients in the outpatient dialysis centers, and how can we try and come up with some guidance statements. We can't make any recommendations because these are not guidelines. We can only make strong suggestions on what should be done for these patients. So as I stated before, based on very small data out there, we try to characterize prognosis for renal recovery and baseline renal function, both the eGFR as well as the albuminuria has a huge impact on the likelihood for renal recovery. As stated earlier, the older age, likelihood of renal recovery decreases with advancing age. The number of comorbidities, again, it decreases the likelihood for renal recovery. And of course, the severity of AKI. So if a patient has been on dialysis and remained oligoanuric for a long time, they also have a less likelihood for renal recovery. And we couldn't really specify that duration because there's no good data. So we decided to characterize the patients as having a high recovery phenotype, moderate recovery phenotype, and low recovery phenotype. And again, this is based on clinical parameters. We purposely decided not to focus anything on a kidney biopsy because, as you know, most patients with AKI are not getting a kidney biopsy unless you're suspecting GN. And so therefore, it's all based on clinical characteristics. So patients who are younger, and with low comorbidities, we're calling them high recovery. So somebody with a motor vehicle accident who had rhabdomyolysis, but may not have had any other comorbidities, they're going to recover, high likelihood of recovery, right? We decided to call the second group moderate, 10 to 30% recovery phenotype. Again, these patients may have some baseline CKD, some limited comorbidity burden, and we thought that, and the patient did not have a long duration of dialysis dependence, somewhere between 30 to 90 days, and then low recovery phenotype. And we didn't say no recovery, we said low recovery. And these are truly patients who had advanced CKD at baseline, older age, significant comorbidities, and prolonged duration of dialysis dependence. So the other thing that happens in the U.S. Centers quite a bit, and I don't know if this is true in Canada as well. So the hospital uses one EMR, and when we are sending these patients to the outpatient dialysis centers, each dialysis company have their own electronic medical record. And essentially, there is very limited communication between, and Epic is primarily used in most of the hospitals at this point in US, at least the bigger hospitals. There's essentially no communication between a hospital EMR and a dialysis facility EMR. I mean, this is where we're still faxing patient information. And if there's no, so in Europe, I was told that there's a nephrologist in the outpatient dialysis center, at least when I talked to some German nephrologists one time, they said, oh yeah, our job is to stay in the dialysis center all day to monitor treatments of those patients. Well, as you know, that does not happen in US, right? We don't even have an APP sitting there all the time. We have an APP rounding once a week. A nephrologist is probably rounding once a month. So nobody's reviewing these records, maybe except the charge nurse, even if you fax it over. And so we really emphasize that warm handoff. Pick up the phone and call the outside nephrologist, discuss the patient's diagnosis, comorbidities, prognosis for recovery, goals of care, right? We don't often discuss this. We just put patients on dialysis and say, oh yeah, we don't know what their wishes are, what they wanted. So recent labs, changes in urine output, dialysis complications, all of this should be communicated by the nephrologist in the hospital to the nephrologist who's going to take care of this patient in the outpatient setting. And one thing that AKI Now, ASN AKI Now work group is working on is actually having a survivorship document, right? If you're leaving the hospital after AKI, just like how cancer patients have a survivorship document, AKI patients should have one of those, whether they're going to the clinic for follow-up or whether they're going to the dialysis unit for follow-up. So we're going to work on a document for both patients, but also something that we can send to the physicians as well. So patient is ready for discharge. Obviously, the patient requires education, and then a social worker in the hospital should assess them for psychosocial support. Remember, a lot of these patients with AKI, they may have been working before, they had a good social life. Now, all of a sudden, they're told that, oh, well, you're just recovering from this. You may have had an amputation of your leg. You need rehab, and now you have to go for dialysis 3 times a week. And so a lot of education for these patients and psychosocial support is essential. And then we're recommending that warm handoff. And then once they get to the outpatient setting, we need to make sure the patients are adequately acclimated to the outpatient dialysis setting with introduction of the interdisciplinary team, and then ongoing AKI-specific education. This is not happening right now in the outpatient setting, partly because the outpatient dialysis staff don't know the difference between AKI and ESRD. And again, they need ongoing psychosocial support of needs and goals of care here, because the psychosocial support that's available to somebody with ESRD is different than with AKI. When you have ESRD, you automatically qualify for Medicare. Well, for the most part, you'll get Medicare. And so you have a certain level of social support, like transportation, for example, which the AKI patient, if they don't have Medicare, may not get. So there's a lot of difference. And of course, medication reconciliation management, MedRec happens just as a checkbox right now in our outpatient centers, just to say, oh, are you taking all those medicines? Check. But there's no active management of these medications in relation to nephrotoxicity, because for ESRD patients, that's not a concern. So we also proposed this for our AKI-D patients. So what happens to patients in the outpatient setting? And again, we made a strong recommendation that these patients get individualized AKI-specific care, which I'll come to, but also ongoing evidence, ongoing evaluation for kidney function recovery. And throughout, so weekly evaluations. And if they're going to transition to ESKD, if there are indicators, you don't have to wait for that 90 days. You can transition to ESKD even earlier if there are strong indications, because like I said, the benefits that a patient with ESKD get is different a patient with AKI. So in the outpatient setting for ESRD patients, protocolized care is the norm, right? We set a standard dry weight. We have monthly labs that are pre-ordered. We have a standard set hemodialysis prescription. We put them on a bone and mineral disease treatment protocol. We put them on an anemia treatment protocol. We send them for vascular access if they don't already have one. And then nobody cares about monitoring urine output renal function. And so when patients with AKI-D are sent to outpatient dialysis unit, they could be scattered around the unit. And I can tell you, a nurse or a technician, I don't know about Canada, but here we have technicians who are the primary caregivers, and the nurses may have up to 8 patients, sometimes 12 patients, with two technicians in the outpatient setting. So a tech is not going to know the difference between an AKI and an ESRD patient. And most often patients with AKI-D are just being put into these protocolized regimen, including having a set dry weight, which, as you know, it's probably not ideal. And of course, there's no guidance for monitoring for kidney function recovery anywhere that I'm aware of. And there's no AKI-D specific quality metrics that we're tracking. So for patients with ESRD, we have to track certain metrics and report that to the CMS on a monthly basis. There's no such requirement for AKI patients. So lot of confusion on how to manage these patients right now, and the patients get lost essentially in an outpatient, especially in a large outpatient dialysis center. They're not getting any focused care. So what's the most important concern for a patient with AKI-D? It's like, hey, when can I stop dialysis? Now, of course, if a patient does not have enough awareness of their disease, they don't even know this is something that they can ask, right? They can ask the rounding nephrologist or nurse practitioner, hey, am I able to get off dialysis? And so this is where education, even prior to discharge, comes in. So we talk a lot about dialysis liberation in this document, and actually we got a little flack from the reviewer who reviewed this saying, oh, should we really call it liberation? Because that's usually refers to liberation of serfs, and dialysis is essentially a life-saving tool, and are you really liberating patients? And we can talk about the semantics, but once dialysis stops being life-saving, when the kidneys recover, in my mind, yes, we should be actively thinking about liberation for these patients from the machine that they're hooked to 3 times a week. So if there are fellows in the room, what I really want to emphasize is thinking about recovery of renal function comes as soon as you put a patient on dialysis, right? This starts very early on. And what do I mean by that? We know that timing of initiation, so how long a patient is on dialysis. We know how the dose of dialysis affects renal recovery. We know the modality is associated with renal recovery, and we know higher ultrafiltration rates can potentially delay renal recovery as well. Let me just touch upon some of these points. So START trial, which all of you are familiar with, RRT-free days at day 90, if you look at the standard arm, was much higher than the accelerated arm. And ATN study, when we looked at the patients who just received hemodialysis in the ATN study, 6 days a week versus 3 days a week, RRT-free days were much longer in the less intensive strategy. So if the more you dialyze, the less they're going to recover renal function. And we see this all the time during our rounds, right? If the day after patient get dialyzed, we know that urine output drops off. And this was also shown in another sub-study of the ATN study, where you can see the decrease in urine output, the significant decrease in the urine output in the intensive group. Association between initial RRT modality and outcomes. This is a post hoc analysis of the START AKI. And again, if you compared the patients who started with CRRT versus IHD, there was a trend towards higher death or RRT independence in the patients who started in the accelerated. And most of this was driven by the RRT dependence at 90 days. And again, this is an association, right? This association with CRT and IHD and renal recovery was also shown recently by Javier Nera and Jay Coyner when they analyzed a large database as well. I used to be a little skeptical about this, primarily because the companies will come and push CRRT on our fellows. And I always used to say, if the patient can tolerate HD, well, is there really a harm in starting that patient on HD? But there are more and more association data. If the patient is hemodynamically unstable, just to avoid that recurrent episodes of hypotension, I think starting CRRT in the ICU for most patients is probably the right approach, or some kind of gentler modality as we see this data, and again, additional data coming out. Again, these are not RCTs. RCTs have in the past have not shown any difference, but those were very small and done very early on in the CRRT era. What about ultrafiltration? Again, this is from Mike Hung's group in University of Chicago, very small study, but it's basically if you have high rates of ultrafiltration, the 90-day renal recovery was lower in that population. So. And similarly, this is also data from the Fresenius group, where it shows that high ultrafiltration rates and urine volumes. So we wanted to emphasize the concept of dialytrauma as part of this paper. Essentially, longer exposure to dialysis, more intense dialysis, aggressive ultrafiltration, more frequent dialysis, all can lead to delay in renal recovery. And so this is a term that we're actually proselytizing outside now. It's like dialytrauma. Think about dialytrauma. Think about when you can take patients off dialysis or wean patients off dialysis. So dialysis prescription for AKI-D, this is data from Ian McCoy at UCSF, where he looked at their satellite dialysis centers and looked at a prescription for a patient with AKI-D versus ESKD. And 94% of patients with AKI-D got the same prescription as a patient with ESKD, 3 times a week. And when he looked at to see where 24-hour urine collection was completed, only 28% of patients with AKI-D ended up having a 24-hour urine completed in the first month. So our guidance statements are that we should be actively looking for renal recovery, monitor weekly pre-hemodialysis creatinine, monitor urine output, and this would include training our staff to ask the patients, hey, are you making more urine? Giving them a urine, something to measure their urine at home and reporting that back when they come in for dialysis. And then we are also strongly suggesting a 24-hour urine for urea and creatinine clearance weekly. We added the urea clearance based on some of the ESKD literature, which showed that the combination of the two may be better than just doing creatinine clearance. We should also be promoting renal recovery, so avoid setting dry weight or target weight on patients with AKI-D. We suggest that volume status should be assessed every treatment and ultrafiltration goals adjusted accordingly. Wean down dialysis treatments with increases in urine output. This is easier said than done for various logistical reasons and just because it's not very commonly done in the outpatient setting. And as patients' urine output starts picking up using high-dose loop diuretics, there's some data from the ESRD literature about how this might be beneficial. And then, we are saying stop and taper off dialysis early. And what does that look like? So there's no uniform criteria, right? In the creatinine clearance, in the ATN study, a creatinine clearance of greater than 12, it was strongly recommended to the treating nephrologist, hey, you can stop dialysis now and watch the patient. In CKD patients, incremental dialysis have been reported even with a urea clearance of greater than 2. The Liberate-D trial, which just concluded, hopefully data will be out soon, utilized a creatinine clearance of 8 ml per minute to hold dialysis. So I strongly suggest that if a patient's creatinine clearance is getting close to 8, we should be holding dialysis, but you can even consider tapering dialysis even before that. And the options to taper could be decreasing the duration of each treatment, but better reducing the frequency of dialysis. And then, like I said, that patient who went to Arkansas, why not just stop dialysis and just do frequent lab checks on that patient rather than bringing them back for additional treatments? And then again, just to emphasize, if we're not tapering off dialysis or stopping dialysis, we're leading to dialytrauma and prolonged dialysis dependence. I think I'm going to skip this. So anemia management, that, full disclosure, lack of evidence, right? We don't know what to do for anemia for patients with AKI-D. We know that it's not beneficial in the critically ill patients as far as giving them EPO. But once patient is transferred to outpatient dialysis, we have no data on hemoglobin targets, EPO use, or IV iron. So our guidance statement said you can start EPO if patient is RRT dependent, greater than 4 weeks, with a goal to avoid transfusion. We suggest keeping targets, hemoglobin targets 9 to 11, similar to ESRD. And then, of course, treat iron deficiency, just like you would do for a patient with CKD or even no CKD, right? So appropriate. We didn't specify the ferritin or TSAT targets. Bone and mineral, there's an area where there's not much data even for the ESRD population as far as clinical outcomes. And so we were very broad here. We just said treat vitamin D deficiency, and we felt strongly that hypophosphatemia is a bigger problem than hyperphosphatemia. And we made a very bold statement here and said, don't even treat hyperphosphatemia unless it's greater than 8. And, we kind of came up with this number on a consensus statement. I don't know how many of you have ever tried phosphate binders, but we used to do this at WashU where the fellows would get a taste of the phosphate binders. And if you ever tasted phosphate binders, I just hate them. It's nasty. And, to give this to a patient just because their phosphate is 5 or 5.5, I think it's torture. So anyway, we can have an argument about this. And, like Mike Hung says, we won the argument, we won the feedback, on some of the statements we had. And we also said avoid giving active vitamin D and other treatment for secondary hyperparathyroidism unless RRT dependent for 4 weeks. Adequacy of dialysis, again, there's a lot of things that goes into adequacy of dialysis, but the only measure that we have, that's recognized is the KTRV urea. I know most people are not big fans of it, but that's the only measure that's out there. So the ATN study recommends 1.2 to 1.4 3 times a week for patients with AKI in the hospital. So we kind of extrapolated that and say, as long as the patient is anuric, we can follow this criteria for our AKI-D patients in the outpatient setting. Medication review, again, we don't have a pharmacist in our outpatient dialysis centers, never have had, but we felt it was important that a PharmD be part of the management for medication reconciliation and active review. We actually suggested that we start ACE inhibitors and ARB early in the post-hospitalization phase, especially for patients with cardiac risk factors who may benefit. We don't have any data on whether we should be reinitiating SGLT2 inhibitors on a dialysis-dependent patient, so we did not have any suggestion at that time in this area. We also created a supplement of a nursing checklist. This was courtesy of Lisa Kester, nurse practitioner at WashU, who is a very vocal patient advocate. And basically, she worked with a nurse in the dialysis center to say, hey, these are some of the things that the nurses should be made aware of, right? Because if you ask an outpatient dialysis nurse, most of them know the difference between the difference between the diagnosis of AKI and ESRD and why a lot of these things are important. So we created a checklist, hopefully that there'll be an uptake in the LDOs and shared with their staff. And then the question is, which path does this patient follow, right? Do they have dialysis independence, or do they get diagnosed as ESRD? And again, once the patient gets dialysis independent, make sure we handing them over to the other nephrologist who might take care of them in the clinic if it's not one of us, with the appropriate medication review and management and patient education on risks of CKD and other complications. And then, of course, transition to ESRD in the US, a timely transition is important because, like I said, the benefits, I just want to make sure I'm on time. Okay, yeah. The benefits of ESRD is very different than benefits that a patient with AKI get. And again, this is where patient family education comes in, vascular access planning, dialysis modalities, and transplant referral. You cannot refer a patient for transplant if they have a diagnosis of AKI. This happened with a patient of ours recently here, where the family was very frustrated. They kept being called AKI, even though they kind of know they have ESRD from their longstanding history of diabetes. And they're like, I still have AKI, so I can't be referred for transplant. And so, just like how it's important to diagnose AKI and try and promote recovery, we need to make sure the right patient gets the transition to ESRD so they can get some of the other benefits. Policy and regulatory challenges in outpatient care. I posed this question when I gave this talk to another group. So in 2016, if a patient had AKI in the hospital and was ready to be discharged on dialysis, we did not have a lot of options. right? And so this is where, if you read the early literature before 2017, there was a high recovery of renal function among ESRD patients in the U.S. Dialysis centers. And I don't know if any of you are familiar with this Form 2728. This is a must for every ESRD patient. A nephrologist has to sign this form for the patient to get the Medicare benefit. And here is a big, bold statement. I certify under the penalty of perjury that this information is correct, blah, blah. And basically the patient has ESRD. Well, a lot of physicians were signing this with AKI because that's the only way we could get this patient out of the hospital prior to 2017. And thankfully, in 2017, the law changed, allowing for AKI patients to be dialyzed in the outpatient setting. But they still don't, that form doesn't really get filled out until the patient has been diagnosed with ESRD. So we still don't have an intake form for patients with AKI in the US. There haven't been many changes since that rule, except this year where they allowed for patients with AKI to receive home dialysis. So until now, a patient with AKI going outside the hospital can only get in-center dialysis and get reimbursed. So even we couldn't even send them to a nursing home and get dialysis on site, because that would be considered home dialysis. So with this 2025 ruling, now they will allow patients to get PD or even get patients dialysis in a nursing home facility. So that's good. Peritoneal dialysis for AKI. So pros, less dialytrauma, increased likelihood for renal recovery, and of course it can be done at home. But the cons of this for a patient who has a good chance for renal recovery, well, you're putting them through another surgical procedure. Patients may have had various GI issues during hospitalization, and of course that may preclude a PD catheter placement. Training takes time. By the time you put the patient through training, they may be recovering renal function. You have to remember these patients have had severe critical illness. They're debilitated. They need physical therapy. They need other things. And they may not have the help at home for PD. And of course, malnutrition in these patients is a concern. So I'm a little on the fence on how I feel. I think it's a great option to have for patients, but I'm not sure how many patients will actually take up on this. Billing, I'm not going to get into the codes for billing here. So our research, some of the research priorities we identified are to develop and evaluate treatment strategies to prevent, dialysis-related hypotension, dialytrauma. I know TED and SWAP are working on this. Investigate whether PD offers significant advantages compared to HD in this population. Identify optimal hemodialysis cessation or weaning approaches in early stages of recovery. Characterize optimal hemoglobin targets and determine the efficacy and safety of IV iron and ESAs in this population. And then, we did have a pediatric group here as well, and they also recommended prospective longitudinal studies of pediatric patients with AKI-D in the outpatient setting. So what would an ideal clinical care look for me? We printed this cool figure. There was a lot of argument back and forth among the team. I'm like, is this really reasonable? I'm like, I don't know if it's reasonable, but this is something that we should be proposing, because we know that, Fresenius and DaVita are not going to be doing this, but, why not propose the best, right? What an ideal clinical care should be looking like. So ideally, these patients should be cohorted, right? We should have better staffing ratio. So there's no guidance on staffing in outpatient dialysis for the ESRD population. Like I said, up to one nurse can staff up to 8 to 12 patients. And so we are recommending that these patients have a higher nurse to patient ratio, not just technician. We need to make sure there's adequate patient and staff and training on AKI-D in the outpatient setting. Again, technicians start working after a 3-month training, maybe less, and they're not getting trained on AKI versus ESRD. We need to identify patients clearly in EMR. We need to have AKI-D specific order sets. We need to have weekly or more frequent nephrology evaluation and with focus on recovery of renal function. And ideally, we should have a pharmacist to review medications. And I would argue the pharmacy part should be for all patients, but maybe especially so for AKI-D patients. From the policy side, we are suggesting integrating AKI-specific quality measures, improving data collection, and expansion of AKI-D-focused research. So to conclude, patients with AKI-D are a small but highly vulnerable population. They really need specialized care in outpatient dialysis facilities, which currently they're not receiving. And that part I don't think is restricted to US because we've all heard stories from other places as well. Focusing on dialysis liberation and avoiding dialytrauma, like I said, active monitoring. When can we take this patient off dialysis? And I would argue this should also happen in the hospital as we round on patients. Sometimes we put patients on dialysis, oh yeah, Monday, Wednesday, Friday dialysis, and we're not actively assessing urine output in between treatments or looking at that creatinine trends. And then we are asking for AKI-D specific order sets in the outpatient setting. This is the wonderful AKI-D guidance committee. A lot of these faces are familiar to you, but we had social worker on the panel. We had a PharmD on the panel. We had Goba Green representing large dialysis organization. And then we had 2 pediatric nephrologists as well. So thank you, and I'm happy to take any questions.
Thank you for that really nice overview, Anita. There is a question from the chat, which I'll read out from Vale, who's asking about volume assessment and dry weights, because often the tendency is to, dry people out as an ESRD. And he's asking if it's practical that volume should be assessed every treatment, and suggesting that maybe we put a target weight to protect the patient from unnecessary ultrafiltration.
Yeah, that's a great question. And again, there's a lot of, absence of data in this area. So we actually almost suggest permissive hypertension and permissive hypervolemia in these patients. And so I guess it'll depend on the individual patient, partly because you're right, it may not be feasible to round on them each time, but at least if we educate the nurses and staff, they will understand that, oh, maybe I should be calling a swap before I decide how much fluid to remove of this patient, right? So I think that's where we talk about a more individualized approach rather than just the standard protocolized approach. Because you're right, some patients may be hypervolemic, they may need extra fluid off that day, or they end up in the hospital with fluid overload. But if we set a dry weight, I'm worried that that's the automatic go-to, and then the nurses or the techs are not thinking about, hey, should I be even assessing something more than, pre-weight is this, post-weight, target weight is this, I'm just going to take the 2 liters off today. So again, this is where I think we will need more, research or at least a practical approach prioritizing these patients.
Yeah, I like the permissive hypertension and permissive hypervolemia. That's a nice concept to push. I know Ted has got his hand up. I'll get to you in a minute. Can I ask you about what are your thoughts about using Lasix in this setting? I know there are not any good data, but I often it doesn't help renal recovery, but it makes you feel good that they're making urine. Is there anything more beyond that by using Lasix?
No, so we did put that in our document, as well as we all felt very strongly that diuretics should be used early on, as soon as this patient starts to produce urine. And part of that data comes from the outpatient literature. I think it was Jenny Flythe who talked about, our early use of diuretics can actually is associated with reduced hospitalization for volume overload, right? And it's association data, but like you said, we all know that patients start responding to loop diuretics early on. And so we're suggesting that, yes, start the loop diuretics, so hopefully you can wean them off dialysis faster. Maybe we need Jay Corner to come up with a furosemide stress test for these recovery patients, right? To see how to predict recovery by using diuretics, but we don't have that yet. Yeah,
excellent. And Ted, one last question before I call upon you from the conference room. Tamara is asking about thoughts on the need for a 24-hour urine collection. Right, in your case, you said, look at the pre-dialysis creatinine. It's clear this patient is recovering. We often do, just pre-dialysis creatinine and volume status to make the decision. And how do you do the, sometimes we do 44-hour urine collections between two dialysis, and then, what's the baseline creatinine and all that? What are your thoughts around just looking at creatinines versus clearance?
Yeah, there was a lot of discussion among our group on this exact topic because, yes, I was also used to doing that 44-hour clearance. But if you think about it from the patient perspective, it's hard, right? It's hard to collect urine for 44 hours, bring it in. So we are thinking a simplified approach. And I had started doing this at WashU even before this. Is, get that collection done from Sunday to Monday or Monday to Tuesday, immediately prior to their next treatment, not immediately after the last treatment, because then you may not be you may have a decrease in urine output. So start it 24 hours prior to their next treatment, have them bring it in, and then you send that for 24-hour urine creatinine clearance. Is it cumbersome? Yes, but I do 24-hour urines in the hospital sometimes just to see if they're making urine, because it's so hard to assess urine output even in the hospital setting. So this is a trigger almost just for a patient to collect the urine, bring it in, for the nurses to say, oh, he made 700, so is it absolutely necessary? We don't know. Again, like I said, there's a lot of unknowns in this space, but I think it will trigger us to think through that process. Oh, the patient made 700 ml of urine. Maybe they are recovering renal function. So I think we suggest that more as trigger people's minds about continue to focus on renal recovery. But we don't have good data. This is truly beneficial.
Yeah, I think we should do more 24 than 44. That's
Yes.
a good idea.
Yes.
Ted from Vienna.
Thanks for that great overview. I guess I was actually going to highlight that, like, Dr. Glavinovich, Tamara, and one of our fellows, Anisha Dalla, just have done a recent quality improvement project where they've developed specific AKI-D order set. But I'm just thinking, like, do you have any suggestions or like tips in terms of like ensuring implementation, how do you operationalize that so that patients are captured? Because I think that's potentially an issue in terms of like who is responsible and how do you ensure that they get put into that pathway?
So do you own your own dialysis center? Because I think that's key.
So so there's a lot of advantages for this kind of thing in Canada because, we're very centralized. So, we are the sole dialysis providers for a population of about 1.4 million. And so it's like we have so our patients move from our in-center units to our satellite units generally.
Okay.
So there's a big advantage there.
No LDO, so you don't have to worry about DaVita and Fresenius and all that.
We don't. It's all public. There's no corporate involvement.
That's wonderful. So I would think implementation would be easier, right? Then, so right now we're actually going through Epic implementation in our centers here. We own and operate like 7 dialysis centers. We have about 400 patients. So we're going to put an AKI specific order set for these outpatients in our Epic dialysis program now. So we're essentially going to say if a patient is going to the outpatient center with AKI, they're going to be on an AKI order set, and then that has orders on urine collection, pre-labs, weekly labs, and so that's how we are planning to operationalize it here in Utah in our centers. Now, when you come to the large dialysis organizations, things are trickier, right? Because everything is controlled at a central level by these organizations. So yeah, I wouldn't know how to implement in that setting. But here, if you have control, I would think that you would start working with your EMR in implementing an order set and then education, all that stuff. Yeah.
No, and so that's been done. I think it's just a question of who's responsible for implementing the order set. Because I think, anyway, I mean, there's ways to think about that.
I think a lot of staff participation, like I guess the unit managers, nurse managers, you need buy-in from them, and creating a flow sheet for these patients that may be separate from the standard ESRD flow sheets. I think all of that will need to go in place.
Yeah, and as you said, this is such a tiny sliver, right, of the ESRD, right? So many of these units will have, one patient a month or one patient
Yeah.
in a few months. So it may be hard. Not that it should not be done, but I guess that's point.
Yeah.
But I guess the other small comment I'll make, just this is maybe like a little bit self-promoting, but I will say like we like I think one of the issues is there's a lot of like overlap between patients who crash into dialysis in the inpatient setting and patients who have AKI. And sometimes it's surprising even the patients who have more advanced CKD that they end up recovering to dialysis independence. And so we did a study where we looked at, like, we used admin data to look at that. But it actually included like about 4,000 patients who would have had a baseline eGFR of over 30. And so I think, the thing is, I think what we learned from that though is that like it was okay, but it's admin data. So like we really need to integrate that with more granular data. And so the question is like, what's the best thing we could collect on day 0 when you're starting in an outpatient unit? And I'm not sure what that is, but my sense is it's a urine right off the bat.
Yes, we are suggesting that.
So that's like every patient when they come in, they get a 24-hour urine.
Oh, okay. When they sorry.
Okay. Well, I wonder if that's a good idea. Like, I wonder if we should think about that.
Oh, you're talking about not just AKI, but even
I'm just saying everybody, because like, I don't know. I mean, every patient who started as an inpatient, at least every patient who's transitioning from the inpatient setting to the outpatient.
Yeah, I don't know if that's the people who crash in. You mean the crash starts? Yeah. Oh yeah. So yeah, I don't know. I have to think about that.
Yeah, interesting. More food for thought.
Yes.
I didn't know about the Liberate-D trial. I think that sounds cool. With like, I think they have 200 patients or so.
Yeah, 240 patients. So I was part of it at WashU as well as at Intermountain. So we basically were randomizing patients to 3 times a week dialysis versus as needed dialysis based on some specific criteria. And so, yeah, we're looking for the results soon. So hopefully
So even in the outpatient setting, they're assessing as needed, or is it inpatients?
Inpatient. So these are patients in the hospital. Yeah. But yeah.
But hopefully that would reduce the frequency of dialysis rather than put them on a cookie cutter 3 times a week program.
Yeah.
Okay, excellent. Yeah, that sounds really cool. But I was just looking at as we were talking at the ASN guidance document, it looks very helpful, especially the supplement with all these checklists. So I think that's going to be a very helpful document. And some of those checklists might be, something we could transition and start using right away. I know there are some nurse educators on the call, so I'm going to definitely pass that on. So yeah, a lot of food for thought. Any other questions?
Yeah, Swap, I can't find my hand from the car.
Yeah.
So I think I agree very much with a lot of what you said, particularly that sense of relief the patients get when you stop. But to counter that, in the distant past, there are a couple of people I stopped and then had to come back a week or 2 later and say, oops, have to restart. We were a little bit premature. And that was devastating. And so I have been, even in people I'm pretty sure can stop while doing the 24-hour urine very frequently, cut down to twice a week. And then sometimes go down to once a week just because I'm not sure about volume status or potassium or, whether the Lasix will work enough. So there are some people who do once a week for a couple of weeks just to make sure before stopping, because I really don't like stopping and restarting.
Yeah, no, that must be pretty traumatic for the patient as well as the nephrologist, I'm sure. So, but yes, I agree with, as I said, like there's a lot of unknowns and little data in how to even wean patients off dialysis or stop dialysis. And so, yes, I agree with you that we really have to be sure, absolutely sure before stopping. Yeah.
Excellent. Thank you for that discussion, and thanks again, Dr. Vijayan, for that, Anitha, for that wonderful overview of the guidance as well as the topic. Hopefully, we'll meet at some future conference.
Yeah. Oh,
maybe
that's right.
in Glasgow next year.
Yes. All right.
Thank you.
All right. Thank you all for inviting me. I really appreciate it. Bye.
Thanks, Anitha.
Bye.